Professor Eto. He is a board chairman of Japanese Medical School International Collaborative Assembly. Professor Eto, please.
Okay, can you hear me?
Yes.
Thank you very much, Professor Yashiro. On the behalf of the Japanese Medical University International Collaborative Assembly, so-called Jamaica, we would like to congratulate our first meeting with the Indonesian University and our society. Our society was established uh, almost 12 years ago and consisted of almost 60 medical university in Japan. And also we aim to promote the international collaboration, exchange for the student, medical student, and also the uh, graduate student and doctors. And this time, we are very much pleased to collaborate together with the Indonesian Medical Society, Association Muhammadi Medical and Health Education to organize international web meeting on traumatology. And this is a very nice, exciting time uh, for the international exchange and support program between Japan and Indonesia. Right now is COVID-19 pandemic infections are now serious in all over the world and also Japan and probably Indonesia. But we must exchange our friendship, our medical knowledge. This is a really fantastic time for us. So on this occasion, we wish to expand our activities for young doctors between two countries. And we would like to continue this kind of activity in our futures. Thank you very much for your great occasion. And thank you very much.
Thank you very much, Professor Eto. And next, I would like to ask the Professor Storisner. He is a board chairman of the Association of Muhammadiyas Medical and Health Education. Professor, please.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin, hamdan na'imin, hamdan syakirin, hamdan yuwafi ni'mahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi jalil karim wa atimi sultanik. Asyhadu an la ilaha illallah wa syarika lahu wa asyhadu anna Muhammadar Rasulullah. The Honorable Professor Yoshikatsu Eto, Medical Doctor PhD, Board Chairman Japanese Medical School International, Collaborative Assembly, Professor Yushiro Yamashiro, Medical Doctor PhD, Vice Board Chairman Japanese Medical School International, Professor Dr. Wamang S. Sukarya, Obstetric Gynecologic Specialist, Counselor of Association of Muhammadiyah Medical and Health Education, Aldin, Member of Association Muhammadiyah Medical and Health Education, and ladies and gentlemen, first let's pray to Allah Subhanahu wa Ta'ala because blessing we can hold international webinar in collaboration between Japanese Medical School International and Association of Muhammadiyah Medical and Health Education. And salat and salam to Prophet Muhammad Sallallahu Alaihi Wasallam. Ladies and gentlemen, this agenda is the first implementation of MOU, Memorandum of Understanding between Association of Muhammadiyah Medical and Health Education and Japanese Medical School International. Special thanks for UHAMKA and Prof. Wawang because they support this webinar can be organized well. Next time, we hope the implementation of MOU is not only webinar, but maybe student exchange, lectures exchange, and maybe research collaboration. And for information, Professor Yoshiro, our members are 12 medical faculty, and each faculty has special distinct curriculum. And finally, congratulations for UHAMKA, congratulations for IPKM, and congratulations for all us. Thank you very much. I think that's enough. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Storisna, for your nice speech. Next, I would like to call the Professor Yuichiro Yamashiro from Japan. He is a Vice Board Chairman of Japanese Medical School International Collaborative Assembly. Professor Yamashiro, please. 山城先生、ミュートを外してください。
Can you hear me?
Yes, please.
Okay, thank you. Good afternoon, ladies and gentlemen. Welcome to international webinar. It's a great honor for me to greet you through online. This is Professor Yamashiro from Tokyo. First of all, I appreciate deeply Dr. Fahad Hansen and Professor Yashiro for their tremendous contribution and effort to organize this webinar. I'm sure this lecture meeting on basic and applied traumatology given by 6 famous doctors from Indonesia and Japan will be successful. I'm grateful to the lecturers for their contribution in advance. Medical students, doctors, please enjoy the lecture. Thank you very much.
Thank you very much, Professor Yamashiro. Thank you so much. And last greeting speech is from Dr. Wang. He is the counselor of Association of Muhammadiyah Medical and Health Education Indonesia.
Thank you, Professor Yashiro. Assalamualaikum warahmatullahi wabarakatuh. Dear colleagues, all the participants in this webinar scientific meeting, our colleagues, lecturers, and students from various medical faculty, our distinguished speaker from Japan and Indonesia. Thanks to the Almighty for blessing us to gather in the international webinar scientific meeting today. The collaboration between the Association of Muhammadiyah Medical Faculty and Health Education and Japanese Medical School International Collaborative Assembly. We are in good condition, especially avoided from the COVID-19 disease. This important meeting will bring us invaluable update aspect about in the medical sciences and technology in the field, especially in the field of the traumatology, in the topic basic and applied traumatology, what medical students and doctors need to learn. In this opportunity, I would like to deliver my sincere gratitude to all the honorable speakers, Professor Takashi Yashiro and Dr. Fahad as the moderators, Professor Eto as the chairman of the Japanese Assembly, and also Vice Chairman Professor Yamashiro, and Professor Miyawaki from GK University, Professor Watanabe from GK University, Professor Takasawa from Gunma University, also Professor Harimoto from Gunma University. Also, thanks to Dr. Ahmad Hidayat, surgeon, and from UHAMKA, and Dr. Corona. This is Corona, not the disease, but this is the man. From the Muhammadiyah Disaster Management Center. Last but not least, thank you to Dr. Lali to manage this program, and I hope it will be useful for us. I truly hope that this meeting will be the fruitful, and we look forward to a benefit tomorrow for all of us. Please enjoy this meeting. Thank you.
Thank you very much, Dr. Wang. You are my good friend. Thank you so much.
Yeah, thank you.
So, ladies and gentlemen, the today's seminar consists of the session 1 and 2. Both sessions will be moderated by the Dr. Fafat Hassan Uhamuka. I would like hand my microphone to Dr. Fafat. He is going to moderate 2 sessions, so long, 3 hours. We are running about 5 to 6 minutes late behind the schedule, so let's go forward. Dr. Fafat, please.
Thank you, Prof. Thank you, Prof. Yashiro. It's an honor to me to be a moderator. Just a brief introduction of me. My name is Fat Hassan. I am a general surgeon and also a lecturer of a medical faculty of Hamka University. I'm very glad today to be a moderator in this webinar. So we will talk about traumatology management, what a doctor and a medical student need to learn. So there are 3 sessions and with three topics in every session. The first topic is about trauma management in general for doctor and medical student. The first topic will be presented by my peer, my senior, Dr. Ahmad Hidayat. He was graduated as general surgeon in 1988 from Medical Faculty of Pajajaran University. And he has experience in military forces. He was joined in Indonesian military air forces for 32 years. And then he has served as chair committee on Trauma Indonesian Surgeon Association. Interestingly, beside as a surgeon, he also has a license in aviation medicine. So I invite you to speak, Dr. Ahmad Hidayat, to begin the first topic.
Thank you, Dr. Fahad, as moderator. It's a great pleasure to me to participate in this webinar. May I share my screen? Is any screen in front of you?
Yes,
Doctor.
Okay. Okay. Dear colleague and participants, WHO nowadays has determined that trauma is a disease, not just diagnosed, but a disease. That's why management for the trauma need the proper thing and will become reducing mortality and morbidity. That's it is an important thing. Okay. We agree that number of trauma increase all over the world, but thanks of God, because the corona, I have data from the Thailand. That's my colleague in Chiang Mai. That's number of inpatient or patient coming to the emergency rooms is decreased because the corona. That means that if we are not a lot of activity in out of house, I think the number of trauma will naturally decrease. Another things, morbidity and mortality is depend on the we are activity in a pre-hospital, inter-hospital, and post-trauma. And I think for doctor who didn't work in hospital, like in first primary healthcare, and for medical student, they can participate in trauma pre-hospital trauma care, and then for them it's important to train as a basic trauma management. The objective for my presentation is how to introduce about the management, and then how to describe the primary survey, initial assessment, and another. And then also when the critical intervention could be made and where to meet them. And then if we have time, I will explain about the ongoing exam and secondary survey. Let me show you about the diagram. It is published from Trunky in 1983. On the left side, if something happened with a patient, injury patient, maybe they will die in a minute. That's mean in the first peak. There's 3 peaks: first peak, second peak, and third peak. In a minute, they will die in a minute. That is called immediate death. We cannot do anything for them yet. And the second peak is early death. If have injured patient and we didn't do anything for them, I think they will die in hours. There is our business. Yeah, our business for saving life the patient. And then the third peak is a patient who will die in weeks because of the multi-organ failure or another cause. But in right diagram, around 2000, the diagram still like that, but like shift to the right. That means that prevention ability for peak 1 is success. For the peak 2 is pre-hospital trauma care is also success. And for peak 3 is how to manage the patient in ACU or OR is also success. That means that nowadays probably we have ability to live the saving the trauma patient. Okay, I take a diagram from the International Trauma Life Support. Yeah, for basic management for trauma life support is the sequences from scene size up until patient load and go to the hospital to get definitive care. And doctor or medical student can participate in trauma pre-hospital trauma care and determine the primary survey until patient load and go by the ambulance. What is the primary survey? Primary survey consists of the scene size up, initial assessment, and rapid survey or focus survey. Scene size up, that means we make a big picture, yeah, big picture in scene, yeah. We can now about the hazard, yeah. Is scene is safe or not? Is there any power lines in a gas or wild animal or in a people will be the danger for us? Also, we can answer, is proper PPE we use for helping the injured, yeah, proper personal protective equipment. Yeah. And another thing is we can also count the number of patients. Usually scene size up do in the inside the ambulance. Sometimes scene size up called the windshield survey. Yeah. And another thing is scene size up is we know about the MOY is multiple, that means cause of injury. Yeah. After finish, we got a scene size up. Another sequence is initial assessment. Initial assessment is how to find the life-threatening problem. A, B, C is airway, breathing, circulation. We can, in 2 or 3 minutes, find the life-threatening problem. Yeah. Initial assessment start with the general impression, level of consciousness, and then don't forget about the how to stabilize the cervical, because a lot of multiple trauma is got a cervical problem. And then start with A, B, C, how to find airway compromise, how to find 6 lethal thoracic trauma, and then how to find is a patient is shocked or not. And then a primary survey's goal is how to identify the life-threatening condition. I think primary survey can did in 2-3 minutes. We can start with initial assessment and rapid survey. Assessment always do and interrupted just if we think that unsafe skin, and if patient had airway obstruction or had cardiac arrest and life bleeding catastrophic, and then assessment is for temporary stop, and then we make an intervention for that criteria. Talking about general impression, if we found obvious bleeding or catastrophic bleeding, right away we can direct pressure or how to stop the bleeding, because it is a problem. Because if catastrophic bleeding, we cannot intervene. Probably patient can going to be worse. Yeah. And with general impression, we know the patient is a patient age, he is a boy, or he is a ladies, or he is a old patient, and then we can approximately know about the weight and another. Also, we can know about the patient position and patient activity. If patient number is more than 1, we can use start multiple triage. Start is a simple triage and rapid treatment. It's how to differentiate it from it is real emergency, life-threatening, or sometimes we can choose with the color, red color, yellow, green, blue, or black. In primary survey, in initial assessment, also we must know about how his patient is concise, consciousness or unconsciousness. The level of consciousness we can determine by if patient is alert, or verbal stimulus, or pain, or unresponse. It is the condition is will change about the manage the patient. We know the first is how to about the level of consciousness, and then with the next sequence is about the airway. The goal, the airway is any compromise for airway? Is any compromise just with the look, listen, and feel? For example, if patient is stridor or gargling, that means that something happened in airway line, and then we must good intervention. It is the goal for the airway. With simple procedure like if patient got gargling, it's just with the suction, probably airway will be clear. And the next is about the breathing. With look, listen, and feel, the goal is find 6 lethal breathing death. They are airway obstruction, tracheolaryngeal injury, tension pneumothorax, open pneumothorax, and tamponade, cardiac tamponade. If we find around the 6 lethal death, we can interpret with the simple thing. But if we don't have any 6 lethal death, I think the breathing is okay. I think all patients just give oxygen with about 15 liters per hour, per minute. Okay. This like respiratory rate. We must know about the normal rate, and then if the old patient has a respiratory rate more than 24, it's a problem for the breathing, something like that. Yeah. For primary patient, is we just find the vital sign like respiratory rate, heart rate, and then about the blood pressure. If while we give an assessment, we find the major bleeding, we must control. Yeah, it's for circulation C. The goal of C is to find any sign of shock. It's simple. We just measure the heart rate and feel about the skin, yeah, and look about the color, temperature, and condition. We know that the patient is with shock. Yeah. Without use the spirometry, we can know about is patient shock or not. It's very simple. And about the MOE decision is important. Because if we know the significant the MOE, we can direct to rapid trauma survey. But if just trauma localized trauma like stabbing stab wound in the thorax or abdominal, we go to the focus exam, not the rapid trauma. It's a simple thing. Yeah, like this algorithm. If the MOE is clear, unknown MOE, we are going to the rapid trauma. If we localized MOE, we're going to focus exam. Okay. Rapid trauma surface consists how to examine from head to the chest, abdomen, pelvis, lower and upper extremity, and back. Probably patient transfer to the backboard if necessary. If something happens, it's critical situation. Yeah. Rapid survey can be completely in the ambulance, not at the skin. Yeah, because sometimes it's about the concern about the time. Well, we must obtain the vital sign, heart rate, temperature, respiratory rate. What about the skin temperature? And also we must know about the mental status. Is a patient is conscious or unconscious? We examine the neurologic exam sometime in ATLS or course is a mini neurologic exam, just via exam pupil, PCS, and sign of cerebral herniation. Okay, this example for Glasgow Coma scale is not. And the part of rapid survey is if we find this dangerous MOE and we have a history of loss of consciousness or high group risk, we direct to the rapid exam. And then also we find the abnormal initial assessment, alter the mental status, problem in breathing, also problem in perfusion, is direct to the rapid exam. If we have time and patient also conscious, we can ask him or ask the another about the sample, symptom, allergic, medication, past medical history, last oral intake, or event the preceding the incident. It is if patient is conscious. And how about load and go situation? Sometimes pre-hospital trauma care, it's just load and go. I think it's depend on the patient. If patient the problem about consciousness, problem about respiration and circulation, and then the sign of shock is clear, I think it's better load and go decision. When in doubt, I think transport is important. Transport early to the hospital. Critical intervention like managed airway, it is from simple, just to change the position and then insert the oropharyngeal airways until the complexity like insert the tube, tube into the tracheal tube, can do in scene or in ambulance. Assist and ventilation, give an oxygen, or sometimes we begin with the CPR. Yeah. But important is control the external bleeding. A simple intervention for tension pneumothorax just with needle decompression, and for open pneumothorax we just seal the sucking wound. Okay. The transport is depend on the patient condition. It's important to go to the hospital, the nearest hospital. Sometimes procedure is not in the scene, like splinting, bandaging, or IV catheter or IV insertion. Also, intubation is not at the scene. I think it's better in the hospital. And then to become transport is will clear, I think we must estimate the time of arrival and also give communication to the hospital that with if patient need a special.
You just have 5 minutes more.
Okay, thank you. If we has time while in ambulance, patient will also exam with ongoing exam. Ongoing exam, that means we examine the patient on the ambulance to examine the patient condition and also for intervention. Yeah. For critical patient, ongoing exam is every 5 minutes, but for stable patient, maybe 15 minutes. Yeah. It depend on the patient condition. ongoing exam is sometimes also in do in ER, emergency room. Why we must get ongoing exam? Sometimes because in ambulance, sometimes a patient will change the condition, change the mental status, also change about the ABC. Before load and go, probably patient in stabilized condition, but on the ambulance, airway breathing circulation will be changed. And then this is a very important that ongoing exam in ambulance is also the priority. Okay, is another exam is a secondary survey. Secondary survey is exam for the patient. The goal is how to find the anatomical condition, anatomical injury. Compare with the primary survey is find to functional condition, life-threatening, but secondary survey is potential life-threatening. Sometimes secondary survey do in emergency, but some if we have time also in the skin. Yeah. Secondary survey is evaluation of injury, not just life-threatening, but also potential life-threatening. Combine to find the functional changes or anatomical injury. But we must know about the baseline condition. Sometimes perform in during transposition, and for non-critical patient can do on scene.
2 minutes more, Dr. Ahmad.
Okay. Don't forget that while we exam secondary survey, we must repeat the initial assessment, repeat the vital sign, and also it is how to examine the secondary survey, like any deformity, contusion, abrasion, penetration, burn, laceration, swelling, tenderness, and other. Yes, completely. Another thing is for patient we need a jump, like we measure the oxygen saturation with pulse oximetry, measure the CO2 with capnography, and also measure lactate. We want to know about the tissue hypoxia. And if sometime ambulance also equipped with the fast ultrasonography, as is very important. Okay, the last my presentation, the small summary about that. Primary assessment is key to the trauma care. It's not difficult, but time is critical. Rapid, orderly, and thorough. Remain calm, maximal speed through the organization, and don't forget about teamwork. The last is how to find the CABC. C is catastrophic bleeding. A means airway compromise. B, breathing problem, and C, circulation problem. Okay, thank you very much for the audience.
Yeah. Thank you, Dr. Ahmad. Thank you for your presentation. So, participant, we just learned about trauma management in general. Basically, as a doctor, you need to know how to make fast and accurate initial assessment, yeah, by primary and secondary survey. Next, we move to next topic. The next topic, we will talk about an update of orthopedic and spine surgery in traumatology. Our speaker is Dr. Takasawa. He is an assistant professor in Department of Orthopedic Surgery in Gunma University Graduate School of Medicine. He finished a medical student in 2006 and finished his subspecialty in spine and orthopedic surgery in 2019. So I invite you, Dr. Takasawa, to speak, please.
Can you see?
Not this presentation, Doctor.
Not this. Oops.
You share the schedule.
Okay.
So participant, if there is any question, you can text in chat box and write to whom the question will be asked for. The question will be read in the end of the session. For Indonesian, if you are uncomfortable in English, just text in Bahasa. Okay.
Okay, let me see.
Yes.
Okay. Okay, can you see?
Yes, doctor. Please continue. You have 30 minutes.
Okay. So it is an honor to give a lecture for everyone today. Okay, so start. So I would like to talk about very basic principle of DCO and fracture management. And my today's topic is spinal cord injury in the elderly in the Japan. Oops, sorry. So let me introduce myself just a little. So I was born in Fukushima Prefecture. Now it is known by the foreign people for the Fukushima atomic reactor tragedy after earthquake disaster. So, but Fukushima is the best place to enjoy seasonal beauty. This picture is Tsurugajo Castle covered with snow in my hometown, Aizu Wakamatsu City. Tsuru means bird crane. The sky is blue and the snow is purely white with silence in winter. So it is beautiful scenery. And now I live in Gunma Prefecture, 1.5 hours from Tokyo by Super Express or by car. So you can visit Gunma for half a day from Jakarta via airplane and Super Express. So I hope that some of you will visit Japan and Gunma after COVID-19. So Gunma University Hospital is located on the campus of the Gunma University School of Medicine in Maebashi City, Gunma Prefecture, East Japan. The hospital and its clinical care center provide advanced medical care in the communities. And the Gunma University Hospital also has research centers covering nearly all major specialties of medicine and nursing, as well as dentistry. Let's move on to today's topic. Traumatic injury is a leading cause of death globally, especially in adolescents and young adults in both Indonesia and Japan. A large number of patients receive some form of trauma-related medical care each year. So, what is the work or role of orthopedic surgery in traumatology? So many years ago, the orthopedic surgeon had been ridiculed as a carpenter in Japan. So, but we're working to reconstruction and repair functions so that patient can live a bright life again. So I think that the orthopedic surgery is an important clinical field for not only the first aid of traumatology, but also patient whole life after trauma. So as you know, a principle of ATLS is to treat the greatest threat to life first, and time is matter for avoiding preventable trauma deaths. The important work of an orthopedic surgeon is to avoid a preventable trauma-related dysfunction or disorders. Our key concept is damage control orthopedics, DCO. So DCO is to prevent and minimize trauma-related disorders. So initial properties are hemorrhage control, soft tissue management, and provisional fracture stabilization. So the work of orthopedic surgeon in the trauma team is to achieve better patient functional outcomes. So we can do the best to save patients from preventable trauma-related disorders. So DCO can prevent trauma-related disorders, but also fatal complications such as ALDS, acute respiratory distress syndrome, and multiple organ failure. And now, a long bone fracture is classified as an emergency that has to be stabilized acutely. So next, I talk about the principle of fracture management and treatment. So please imagine, now you are resident in a clinical care center. A trauma patient complaining of left knee pain is transported into an emergency room. You may examine and check a radiograph of his or her left knee. So how do you report radiographic finding to your consultant or attending doctors? How do you manage and treat this patient? So management of fractures has 3 steps, very simple 3 steps: span, scan, plan, or scan, span, plan. Often scan, span, rescan, and plan. So it may sound like a magic spells. So scan means precise evaluation of fracture by CT scanning. First, CT tells a lot more than plain X-ray. So degree of atrial depression often is underappreciated on plain radiograph. Second, CT gives a better 3D image. Third, CT allows accurate measurement and classification of fractures. So can you find fracture lines in many bone fragments around the knee joint? It seems to be an unstable and multi-fragment tibia fracture, by high energy trauma. This patient may have severe soft tissue damage. So how should we do next? So SPAN is preliminary reduction of gross malalignment and immobilization of the involved joint. So spanning could be achieved with external fixator, and spanning can buy time for planning and soft tissue management. So using external fixators, the fracture site is spanning for preliminary reduction and immobilization for the definitive treatment. So we should classify what type of this fracture is. So AO classification composed by Orthopedic Trauma Association and AO Foundation is a common language in orthopedic trauma team. The principles of classification are based on understanding and applying standardized definitions. The definitions are universal and allow consistency in classification and communication. Clinical decisions are sometimes made on incomplete information, but this should be avoided as much as possible. So classifying our fracture provides a more precise description and better data decode. So as you can see, this figure shows the designation of bone location. So fracture sites or locations are coded by bones and segments. For example, proximal tibia is coded FO1. A simple to quick variation of ABCs for a primary vital survey, airway, breathing, and circulation. ABC variation for fracture classifications is a common language in a trauma team. So ABC evaluation is simple, practical, and useful. The morphology of the shaft diaphyseal fracture is defined as three types. Type A, a simple fracture, have a single circumferential disruption of the diaphysis. Type B, wedge fracture. So fractures are characterized by contact between the main fragments after reduction. So usually restoring the normal length of the bone. The wedge fragment may be intact or sometimes in multiple fragments. Type C. Type C is a multifragmentary fracture. So fracture consists of many fracture lines and fracture fragments. So these fractures were known as either wedge or complex fracture in the Mueller comprehensive classification. So complex is the term that caused the confusion because it is non-specific and is replaced in a 2018 version classification. The morphology for end segment fractures based on whether they are extra-articular or intra-articular. So type A, extra-articular fracture. So fracture line may be metaphyseal or epiphyseal. So that it always spares the articular surface, although it may be intracapsular. So partial articular, type B, the fracture involves a part of the articular surface. So while the remainder of the joint remains intact and is solid, connected to the supporting metaphyseal and the diaphysis. And lastly, a type C. Type C fracture is complete articular fracture. So there is a disruption of the articular surface, and articular surface is completely separated from the diaphysis. So the diagnosis was AO41 type C proximal tibial fracture with posterior column fracture. So when we're planning, so we should consider fracture type, the soft tissue condition, and functional requirement. So reduction strategy of fracture fragment, choice of imprint, and surgical timing and staging are important ingredients of our plan. So after planning, so we performed definitive surgical treatment. So in this case, lateral and medial dual plating and posterior buttress plating were also performed, and with anatomical reduction of articular surface and artificial bone grafting. So ABC classification system for evaluating spinal injury is also available. So type A is vertebral body fracture, such as completion or a bust type fracture. Type B is tension band injury. So tension band means includes a posterior ligamentous complex to stabilize spinal structures. And type C is displaced spinal injury. Most of the cases have vertebral injury and tension band injury. And type C spinal injury is closely associated with severe neurological injury. So here it is a case presentation. So L52 type C thoracic spine fracture dislocation with severe spinal cord injury. So for this patient, we performed posterior decompression and instrumentation with screws and rods to minimize neural damage and stabilized unstable spine.
I'm sorry, Dr. Takasawa.
Yes.
5 minutes more.
Okay. Another case, so now we can treat spinal injury with minimally invasive spine surgery. So this type of surgery uses smaller incision than standard surgery. This often causes less harm to nearby muscles and other tissues. It can lead to less pain and faster recovery after surgery. So next, I would like to talk about my topic, spinal cord injury and the elderly in Japan. So those are graph of population age distribution in Indonesia and Japan. So as you can see, aging is accelerating in Japan compared to Indonesia. So over the past decades, the number of cervical cord injury associated with poor among older adults has continued to rise, emerging as a major public health in Japan. So such spinal cord injury is mostly incomplete, caused by low energy trauma and associated with pre-existing canal stenosis due to degenerative change or ossification of the posterior longitudinal ligament, OPLL. So this type of spinal cord injuries are gaining attention from clinicians with a recent rise in SCI among the older people. So as you see the scheme, pre-existing degenerative narrow canal due to CSM or OPLL cause spinal cord compression. So therefore, it is easy to damage spinal cord even by low energy trauma such as force. So it is the treatment strategy and the timing of surgery have been still debatable, but in the near future, the interesting paper will be published from Japan. So finally, I would like to introduce my colleague, my member of spine team, to which I belong. So this is a picture of my colleague department, orthopedic surgery, Gunma University Hospital. So this is a represented program of orthopedic trauma surgery in our department. So first 2 years, general residency, which is called Kenshui in Japanese, trainee doctor. So the young doctor have orthopedic residency. Some of the young doctor aiming to become orthopedic trauma surgeon. So they have fellowship in a trauma center outside Gunma Prefecture to broaden their knowledge and friendship. That's okay. So finally, so basic and clinical research is also an important work for us. So one of our research is developed. Finish? Okay.
2 minutes more, Doctor.
Okay, thank you. So, so one of our research project is to develop a novel treatment for osteoporosis. So as you know, Japan is an aging and aged society. So osteoporosis-related fractures, such as femur bone fracture, is closely associated with mortality in the elderly. So we focused on the extracorporeal shock wave therapy, so-called ESWT. So this treatment modality is safe in practice, and it is already used the treatment of ligament and other soft tissue injuries. So this project is now running in our laboratory. Okay. So thank you so much for your kind attention. I hope we can meet someday. Thank you so much.
Thank you, Dr. Takasawa. What an excellent presentation. I interested with the magic spell scan, span, and plan. Okay, scan how to we see the fracture pattern anatomy. Span how to minimize the realignment of the fracture, and plan how to determine the suitable surgery, definitive treatment. So. Okay, and for you participant, you should know that in orthopedic trauma, after saving life, the importance also in good orthopedic trauma management is how to preserve the function of extremity. Thank you, Dr. Takasawa. Next.
Thank you.
Okay. Next, the end of this first session. Our speaker is Professor Harimoto. Professor Harimoto is associate professor in Division of Biliary and Pancreatic Surgery in Gunma University. He graduated as a medical doctor in 1999, and he finished residency in 2001, and he finished the subspecialty in March 2006. He also has so many certifications, like as a hepatologist, gastroenterologist, transplant surgeon, and endoscopic surgery. So the topic is about abdominal blunt trauma management in Japan. To Professor Harimoto,
yes.
I invite you to speak.
Yes, thank you for introducing me, Professor. Okay, can you see?
Yes.
Okay. So I'm Norihumi Harimoto from Gunma University. So today's topic is abdominal blunt trauma management update in Japan. Especially, I will talk about liver and pancreas injury. So now let's get started the lecture. So this slide shows the number of deaths in 2019 in Japan. Unexpected accidents include trauma. So every year, about 20,000 people are killed in trauma. Unexpected accident is the main cause of death among children and young people. So this is a Japan Trauma Data Bank report 2020 from Japan Association for the Surgery of Trauma. So the most common cause of injury are fall and motor vehicle. Commonly injured organs are lower extremities, but abdominal trauma is not so common, but it can be fatal. This slide shows the abdominal injury site. So blue is liver and red is pancreas. Liver injury is the most common among abdominal injury. So I am a hepatobiliary and pancreatic surgeon, so I would like to talk about liver and pancreas injury. So when you meet a trauma patient, you should check vital sign and fluid retention using ultrasound quickly. If you detect effusion and symptom of shock, the patient needs rapid infusion because of suspicious bleeding. Various examinations can be done if patients respond to infusion, but non-responder will require emergency surgery. The Japanese Association for the Surgery of Trauma defined liver injury to 3 types according to the degree of liver injury. So type 1 is subcapsular injury. The liver capsule is preserved and non-intra-abdominal bleeding, but it is important to observe change over time. So type 2 is superficial injury. An injury is within 3 centimeters in depth. The liver capsule is not preserved, but there is intra-abdominal bleeding, but no large blood vessels and bile duct damage within 3 centimeters. TAE may be required. You should be aware of delayed bile leakage or pseudoaneurysm. So type 3 is deep injury, and the injury is over 3 centimeters in depth. The liver capsule is not preserved, and major vessels are injured. In summary, treatment of liver injury is according to the injury type. Treatment was selected according to the type of injury and vital signs. As you can see, damage control surgery is needed for type 3B injury. The damage control surgery is treatment strategy for severe trauma cases. The purpose is to control bleeding and ataxia. Procedure of hemostasis can be performed in the shortest time. Stabilization of general condition in ICU after initial treatment and planned reoperation, such as final reconstruction and wound closure. So this is a case presentation of liver injury type 3. 17 years old female had head-on collision with a 4-ton truck while riding a minicar. She was taken into our hospital as an emergency with sign of shock. The primary survey showed peripheral circulation insufficiency, and ultrasound sonography showed abdominal and thoracic bleeding. So this is a laboratory data. So you can see elevated liver enzyme, anemia, and metabolic acidosis. So X-ray showed reduced lung permeability, so fast positive. The diagnosis were abdominal bleeding, bilateral hemothorax, metabolic acidosis. So this is a clinical cause from injury to initial surgery. She was non-responder for rapid extracellular fluid infusion, and we took her to the OR 52 minutes after initial arrival. This is a first finding of first surgery. The bloody ascites was observed during laparotomy. So spleen rupture and liver injury type 3 and IVC laceration. The performed operation was splenectomy and liver injury type 3 and the suture for liver injury and IVC and gauze packing. It took only 18 minutes. This is a clinical course after first surgery. There was severe acidosis, although we need bilateral chest drain and TAE for liver injury in ICU. Blood loss was decreased, and second surgery was performed to remove the gauze because of improvement of acidosis. So she became DSE and ARDS after second surgery, but she got third surgery, and finally she could discharge 1 month later. Second surgery was performed to confirm hemostasis. We do gauze removal and mesh closure 36 hours after first surgery. So you can see the congestion of left lobe of the liver. So this is a finding of third surgery. So left lobe of the liver became necrosis, but general condition was stable. We did lobectomy of the liver 9 days after first surgery. She got well, and finally she could discharge. So it is necessary to perform laparotomy and hemostasis without delay for patients with non-responder. Severe liver injury is often associated with multiple organ injury. Several surgeries may be required to improve general condition in ICU. So next theme is pancreatic injury. Same with liver injury, pancreatic injury was also divided into 3 types. The biggest difference is that type 3B pancreatic injury is with damage to the main pancreatic duct. This is a very important thing. In patients with type 3B, endoscopic approach is sometimes selected to secure the main pancreatic duct. So this is an algorithm for management of pancreatic injury. It is important to confirm if there is main duct injury by various modalities. Treatment strategy of type 3B pancreatic injury was different by the location. So now we will make presentation of 4 cases. So case 1, 75-year-old female was injured by fell off the bridge. So CT scan shows a grade 3B pancreatic laceration at the pancreatic tail and extravasation from splenic artery. So you can see the abdominal fluid. This is a laceration. So massive bleeding from splenic artery was confirmed by angiography. Emergency operation was need to control the bleeding and to treat the pancreatic laceration. So that laceration was found at the pancreatic tail. Bleeding was detected at the splenic artery. Distal pancreatectomy with splenectomy and abdominal drainage was performed. So operation time 160, blood loss was over 2,000. So case 2, 11-year-old boy had blunt abdominal trauma due to failure on block. On admission, pancreatic injury was not detected, by plain CT scan. So 2 days after, enhanced CT scan shows a grade 3B pancreatic laceration at the pancreatic tail. The abdominal fluid was increased for 2 days. We decided to operation. So you can see abdominal fluid. There is a laceration. So laceration was found at the pancreatic tail. Spleen-preserved distal pancreatectomy was performed because the patient was a child. It is important to preserve spleen in children. Pancreatic injury was limited at the pancreatic tail. So case 3, 70-year-old man was injured by traffic accident. On admission, ascites was found, but extravasation was not detected. 2 days after, CT scans showed pancreatic contusion at the pancreatic head clearly. The fluid collection was increased around pancreas head. So you can see abdominal fluid. There is a contusion. MRCP detected the pancreatic duct at the pancreatic body and tail, but pancreatic main duct continuity was not confirmed. Main pancreatic duct injury was suspected. So abdominal drainage operation was performed. The contusion was confirmed at the pancreatic head. We placed 4 drainage tubes near the pancreatic head. This is a clinical cause. The CT scan shows the drainage tube were located around the pancreatic head and drained pancreatic juice. So pancreatic fistula was limited to 1 drainage. At the last drainage was removed 223 days after surgery. But we could avoid pancreatic total-donectomy. So case 4, 23-year-old female was injured by traffic accident. The massive disruption of the pancreatic head and the body with lack of continuity of pancreatic duct. So you can see abdominal fluid. So this is there is no continuity. So MRCP detected the pancreatic duct injury at the pancreatic head. So ERCP detected pancreatic duct injury at the pancreatic head. Through the cavity, distal pancreatic duct was enhanced. The guide wire was cannulated to distal pancreas. So ENPD was able to place through the injured duct. So this is a clinical cause. A leak of pancreatic juice decreased and the ascites was disappeared after 7 days. She could discharge 1 month later, and after several times changing, pancreas tube was removed after 385 days of initial treatment. So surgery for type 3B pancreatic injury should be considered according to the vital sign. Endoscopic approach for type 3B pancreatic injury is less invasive treatment, but it takes time to heal. So this is a last slide. So it is important to select appropriate treatment for various therapeutic methods depending on the condition of the patient. So thank you for your attention.
Thank you, Professor Harimoto.
Yes.
Thank you very much As a general surgeon, it is pleasant to learn from your cases. In Indonesia, unfortunately, TAE or trans artery embolization still not popular performed because of limited expert and facility.
Yeah.
But we do damage control surgery routinely. And I'm amazed with the response time in trauma treatment in your country. From the event of injury to the OR, only need 1 or 2 hours. It's very fast response. Thank you. This is the last topic of the session. This is the end of the first session. So next, we move to Q&A session. We already received the question from the chat box. So I will read the question. Yes. The first question from Dr. Iren from Medical Faculty of UHAMKA to Dr. Ahmad, General Surgeon, PhD. The question is, if we find a clinical patient with tension pneumothorax in a public place, what can we do? Please, Dr. Ahmad.
Okay. This direct answer, Doctor? Yeah. Okay. Thank you, Dr. Irena. It depends on the condition. If you are trained, if you are equipped, and the scene is far from the hospital, I think this simple intervention like the needle thoracentesis is easy, yeah? But it's difficult to find is it really tension pneumothorax or not. Yeah, but if we examine the patient with look, listen, feel, yeah, and then the patient is like the pain. I think it's a real tension pneumothorax without X-ray. The important thing is we find the tension pneumothorax with a simple intervention like needle thoracentesis is success. That another things is depend on the situation. Thank you.
Thank you, Dr. Ahmad. I think all doctor, including GP or other specialists, must be able to treat tension pneumothorax because the technique is very simple. I think you agree, Dr. Ahmad?
Yeah. But nowadays, I think the location for needle thoracentesis, needle thoracentesis is move from intercostal 2 to intercostal 5. Yeah, it's for safety. Now, nowadays, the perform needle thoracentesis not at the intercostal 2, but move to intercostal 5 in lateral position. Okay.
So that is an update, right?
Yeah, it's from ATLS 10 edition.
Okay, I just to know about it.
Yeah.
Still now in ICS 2. Thank you, Dr. Ahmad, for the lecture and for the answer. So next to second question. The second question from Taka Fujimaki from Saitama Medical University to Assistant Professor Eiji Takasawa, MD, PhD. The question is, as for severe spinal injury, since the spinal cord damage cannot be rescued by emergency surgery, how quick should we do surgery?
Thank you for a question. it is difficult so to answer. So as you know, so the timing of surgery is debatable. So, but I think my opinion. So for a severe spinal cord injury, we should perform surgery as soon as possible for neuroprotection. So, and so in my talk, so I talk about incomplete type spinal cord injury without radiographic abnormalities. So, but such patients, early surgery within 24 hours is associated with great improvement of Asia motor score. So now under debatable, so that I should early surgery in both situation.
Okay, Dr. Takasawa.
Yes.
There is still recommendation about giving high dose of corticosteroid in spinal cord injury.
Mm-hmm. So steroid pulse treatment is now, I think, not recommended in many guidelines. So, but of course, I sometimes use corticosteroid. So for the patient without diabetes mellitus and so on, and other comorbidities.
So your recommendation, corticosteroid will suitable to give in what hour from the event of injury?
Sorry, from the injury, timing?
Yeah. What is suitable corticosteroid injection to give? What time after the surgery?
After surgery, just 1 or 2 points. Just after surgery and 12 hours after surgery, so 2 or 3 points.
Okay.
If we use corticosteroid after surgery, okay. But case by case.
Yeah. So I also have a question for you, Dr. Takasawa. Maybe it's important to doctor.
Okay, so I think a little bit similar question. I think so. So today I talk about an incomplete spinal cord injury in the elderly. So such patient has a pre-existing canal stenosis due to our cervical spondylitic myopathy or OPLL. So I think so we should perform surgery. So because they are already have a narrow canal and the cold compression. So and subclinical myopathy exists in such a patient. So what do you think? So this kind of treatment in your country. So do you have such a case, spinal cord injury without radiographic abnormalities?
Sorry, I'm afraid I'm not that in specialty.
So I think so. Saiwara, so in child, spinal cord injury without radiographic abnormality. So I mean, such cases is familiar to you. So, so in my talk, so I talk about spinal cord very subtype of spinal cord injury in the elderly patient. So I think so. Treatment is different by generation, I think.
Yeah. Okay. Beside the surgery, rehabilitation or non-operative management in spinal cord injury is also exists and still debate. Thank you, Dr. Takasawa,
Thank you.
for the explanation. Also, the next question you again, Dr. Takasawa. Are close fracture reduction procedures still frequently performed? If so, what should be evaluated afterward?
Oh, gross fracture reduction. So, yeah, I think so. Now we do the close, sorry, and cross fracture reduction. Yes, I think so. So,
I think
so key point. What is the key point in this this question?
I think after a close reduction close fracture reduction, we should evaluate about the alignment and then the vascularization at the end of finger at the distal extremity. It's very important to look afterward the vascularization, the alignment. When we find the sign of compartment syndrome.
Yes, I think so. Yeah.
You should be aware about that. What do you think?
I agree with you. So I'm same opinion. Oops.
Okay. So I think that's an answer. Beside the alignment, also vascularization is important to assess after you perform a close reduction. So the next question, you are favorite, Dr. Takasawa, you are favorite. If the operation is less than 24 hours is debatable, is there any initial therapy should be done as a general practitioner for limb salvage?
So in the patient with severe soft tissue damage, so should be transported to critical care center as soon as possible, I think, because and so repairing the blood flow and soft tissue management is very specialized treatment. So just simple fracture is stabilization by a simple plaster is okay, but severe complex trauma is a little bit difficult for I think GP and other medical staffs. I think very specialized management, I think.
Dr. Takasawa, do you recognize about mangle extremity score?
Oh, yes. I know. Okay.
So I think we should know about mangle extremity score in the first one. If the cutoff point of more than 7, so the limb salvage is less, right?
Sorry, I can hear you now.
Do you agree with mangle extremity scores in the first assessment of extremity injury, Dr. Takasawa?
Sorry, I can your voice very noisy now.
It's okay. So I think we are as a GP or a trauma surgeon, we should know about and we should recognize about mangle extremity severity score. As I know, if mangle extremity score cut-off point more than 7, salvage is less. Yeah, we may considerate about limb amputation. If the cut-off point more than 7. Do you agree, Dr. Takasawa?
Yes, I agree.
So you may learn. I mean, the participant may learn about the mental extremity score. So the next
Okay,
session,
I see.
maybe there is one question more. Okay. If there is no question, I will. Okay. Again, Dr. Takasawa, for you, please.
Now it's on the osteoporosis. Yes. So could you teach me KNESS is what is a KNESS?
Yes, that is why I would like to know is on osteoporosis. Could be a non-surgery. I think the osteoporosis knee treatment, there is non-operative treatment.
Mm-hmm.
Yeah, I think yes. I think, as I know, the osteoporosis knee could
A knee?
non-operative but also there is a operative like knee replacement, right?
I see. Okay.
So what is the indication of knee replacement in the case of knee osteoporosis?
So I'm sorry, I have answers. So I'm not my field. So I'm sorry.
It's okay,
Professor Tasakawa, because you have explained about the fracture of the knees. Yeah.
From the, to Dr. Wawang or the.
May I? Because you have explained about the fracture of the knees and how to operate it, and I would like to know: is it always to do the operation for the osteoporosis, for example? Is all the osteoporosis to be operated or not? Or
yes, operated. So for the yes, so for the patient with osteoporosis, also performed surgery. So because I think it is important for storing bone stock for they need. So if they need our total knee arthroplasty or other surgery, so we often use a kind of bone modifying agent, teriparatide and other agents. So perioperative term. So and then so we perform the surgery, including our fracture management and arthroplasty and so on.
Okay, thank you.
Thank you, Dr. Takasawa. I think one more question, if there is for Professor Harimoto, there is a question for Professor Harimoto.
Yes.
Professor Harimoto, the question is, in abdominal trauma patients, should imaging or investigation always be performed before performing surgery?
Oh, yeah. So imaging is very useful for the surgery, but if patient is unstable vital sign, so we have to do surgery first. The first patient we do the rapid extraocular fluid infusion. So patient is responder, so vital signs stable. So we can check the CT scan or some various laboratory data. But if patient is unstable, so we call non-responder, we do the surgery first. Okay.
Yeah. Thank you, Dr. Hariboto, Professor Hariboto. I agree about that. So the point is, if the patient unstable, uh, if the patient unstable, we do less invasive imaging such as USG fast. And if we find there is split collective in USG fast with the history of trauma in abdominal region with the shock condition, so the surgery may be performed without CT imaging, right, the professor?
Yes,
Yeah.
we agree.
So, Professor, I have a question for you. My question is the diagnosis of pancreatic injury is very challenging. We may miss the pancreatic injury in the first day or several days.
Yeah.
So, what is your opinion? Is there is a trick to make diagnosis as soon as possible?
So it is difficult to diagnose correctly. So we have to check the CT scan several times, or so some other modality such as MRCP. So, or if we the pancreatic duct injury was suspected, we do ERCP secondary. Yeah.
So, if there is no facility such as MRCP, will amylase and lipase serial will be benefit to diagnose?
Yeah, sometimes, yeah.
Thank you, Professor Harimoto, for the explanation. So there is a question from Putri. Putri is forensic. Maybe she is forensic residents or what? So the question to all speakers: from the features of the injury, can you determine the direction of trauma or force for accident reconstruction purposes? Can you determine the direction of trauma for accident reconstruction purposes? I don't. I'm not quietly sure what is the question. Maybe Dr. Ahmad, you can answer first.
Okay, I think for trauma patient, it's depend of the mechanism of injury. Yeah, if you know, we know about the mechanism of injury, and we can know about the force, the energy to hit the patient, and then like lateral side force or for the upper or for the back. I think it's very important when it is important to become as a plan for the reconstruction. Jadi I agree that it is very important to know about the direction of the trauma force. Yeah, we know that from the mechanism of injury. Yeah, thank you.
Yeah, thank you, Dr. Ahmad. Maybe another speaker. Would you explain? I see the direction of trauma will be determine, yeah, the reconstruction purposes. So if it is important to anamnese or ask the patient or maybe the family or maybe the person who bring the patient about the mechanism injury. For example, if we see the wound in the right side, so we can predict the patient maybe fell to the right side. Or if we find the press fracture in head, we can predict the trauma mechanism caused by small objects such as hammer, or he fell onto a small rock, maybe like that. The explanation of the question. Thank you for the question to all participants. Maybe there is another question. We still have a time until 10 minutes more.
I have one question for Professor Harimoto. Is possible?
Yeah.
Okay. In your country, who is do for TAE, trans arterial embolization? Is it a surgeon or radiological intervention?
So in Japan, so TA is performed by the radiologist.
Or radiologist, okay.
Yeah.
What about in bleeding or shock? You use for TXA, tranexamic acid.
Oh,
TXA injection for hemostatic agent.
So I don't know in detail, but the first is sponsor, I think.
Okay.
So and next is coil embolization.
Okay. Thank you.
Thank you.
Professor Harimoto, I also have a question. It is interesting to see your first cases about liver injury.
Yeah.
So it written the patient has performed IABP, intra-aortic balloon.
IABP, yeah.
Perform or what?
So that treatment is by the emergency doctor.
Yeah, for emergency.
So yeah, so to help the internal medicine. So there are some specialists to get together. So to save. So she was a very young patient.
Yeah. So AABP. So you didn't perform AABP, right?
No.
But the response time is very fast, very fast. Okay, if there is any question, I think it should be enough to end the first session. So back to we move to, before we move to second session, there is a break time, right? The committee.
Yes, we are.
Yeah. I think we need a break time just for 2 or 3 minutes. Please don't go anywhere, because after this break time, we continue to the second session. Thank you very much.
corona datang menyebar, dunia jadi gempar, banyak yang tertular, korban berguguran, yang mati berturutan, negeri pun kelabakan. Tenaga medis, TNI, Polri, relawan sibuk berjibaku tanpa kenal waktu, capek lelah ketakutan tak lagi dirasakan demi kemanusiaan. Hey hey hey, cuci tangan dong, pakai masker dong, jaga jarak dong. Ayo cegah corona, diam di rumah saja. Yuk untuk kita semua. Tenaga medis, TNI, Polri, relawan sibuk berjibaku tanpa kenal waktu, capek lelah ketakutan tak lagi dirasakan demi kemanusiaan. Hey hey hey, cuci tangan dong, pakai masker dong, jaga jarak dong. Ayo cegah corona, diam di rumah saja. Yuk untuk kita semua, untuk kita semua.
Okay, what a good song. And I don't know, my dean is also musician and he composed a song to Dr. Corona. So I hope all of you still have energy to finish the webinar. If you like emergency cases and traumatology, you must be excited to finish the whole webinar. So in the second session, there will be 3 topics. 1 speaker from Indonesia and 2 speaker from Japan. In the first topic of the second session, Dr. Corona Rintawan will be speak about the role of medical doctor at disaster, lesson learned from MDMC. Dr. Corona Rintawan has specialization in emergency medicine. He is emergency medicine specialist. He finished the specialty program in 2018 from Brawijaya University Malang. He nowadays he worked as vice chairman in Muhammadiyah COVID-19 Command Center, Muhammadiyah. And then he also worked as special staff in National Board Disaster Management. And he also actively involved in disaster management nationally and internationally as medical team coordinator. Dr. Corona, I invite you to speak your presentation, please.
Thank you, Dr. Fahad, for the time. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Alhamdulillah, Bismillah, wala haula wala quwata illa billah. Good afternoon. The Honorable Prof. Yoshikatsu Eto, Prof. Dr. A.M. Sutresna, Prof. Yushiro Yamashiro, Dr. Wawang, and Prof. Takashiro Yashiro. Distinguished speakers and participants, it's been an honor for me to be invited in such a special webinar, international webinar at this time, conducted by the Universitas Muhammadiyah Dr. Hamka and Japanese medical schools. Please allow me to share some of my experience during the disaster. But my topics is, I think, is very different than the other topics for this special occasion, because it's a special request by the committee, Dr. Lely. So I hope it will give some additional perspective for the medical student in Indonesia and UHAMKA, and also in for maybe some of the Japanese medical students. Okay, so I will start. I will try to do the quick presentation. I hope not more than 30 minutes. The data rules in disaster site. So when you talking about the disaster site, we all aware that the condition is very different than the normal condition. So we are all, as doctors, must prepare for anything. The most, in my own experience, tell me that the most certain in disaster site is uncertainty. So I think it's we all must aware about it. So the disaster medical doctors' roles and in disaster site. First, yes, we will act as doctors. That's I think the main job for us in disaster site. So what we do is we assess the patients, we examine the patient, we triage the patient, and we treat the patients. And some of the cases that we need to refer the patient to the higher medical facility in disaster site. Depends on what kind of the level we work at the disaster site. So we can do the, like minor surgical cases, and minor sutures, and some of the non-surgical cases. I think it's not a debatable function for us as medical doctors in disaster sites. Although many of time we deal with on understandard condition in disaster locations. Depends on the preparation of the local government, and also what we call it now is EMT, emergency medical team in disasters. The second role for us is, we as doctors can be function as a team leaders. It means that we lead the teams, we command the team, we coordinate the teams so that our team can work optimally in disasters. We also must plan, yeah, for our EMT operational plan. So we also act as a planner for our team to be to work optimally in disasters. And also as a team leaders, we monitor and evaluate our our medical team operational plan daily, and maybe if your team work in a month, yeah, in the end of the deployment process, you can also evaluate your your team. The third is we can be also act as the license officers for our team. It means that we are representative of the teams during the meetings with other stakeholders uh, in in international levels or even in the local levels of the meetings. And also can be mediators for stakeholders that participate in that kind of meetings. So yeah, in my experience, it's not only act as a, you know, like treat the patient, but we also have to have a capability to communicate with other stakeholders, yeah, especially when we are working in the disasters situation. We also sometimes have to have capability to be a designer for our AMT facility or our medical facility. Yeah, because it's in my experience, it's very rare that the doctor have capability to, you know, to plan the site for our camp and to arrange the patient flow at our camp. So we have to practice in such kind of ability. So when deployed, we are deployed to the disasters, and we deal with the unexpected, yeah, unexpected reality of the locations. So we have to adapt and modify the previous layout of our camp facility. So yeah, sometimes we have to be a designer. Yeah. The next is for a medical doctor. We we can also act as negotiators, especially when the local governments expect us to do something that was not our mandate, yeah, from our organization or from our government. So we need to negotiate and with the local governments so that our medical team can have the best interests, yeah. And also many of the situation in the disasters dealing with the local policy that was not normally the same, yeah, the same with our our own policy, especially when we are deployed to other country. Yeah, sometimes even though in the national level, for example, in Indonesia, we have thousands of tribes and local cultures that need, to be understand. Yeah, and for EMT or emergency medical team or medical team in such that conditions, we need to truly carefully negotiate. Yeah, for the with the local authority, especially with the tribes, the community leaders. Yeah, during our assignment. So yeah, doctors can be as the negotiators also in the disaster sites. The next, when you don't have enough human resources in your teams, you also have to be a logistics person, you know, uh, divided into a medical logistics and general logistics. Yeah, we do that kind of rearranging the medication and also to establish a tent, maybe sometimes to help the logistic officers. And also we are dealing with the IPC, yeah, IPC procedures. Yeah, so in many times, especially in Indonesia, sometimes it's hard for us to send the, like the whole teams. In WHO standard for the EMT type 1, it is said that minimal we have 24%. Yeah, but in reality, is in national level, it's not easy to send 24% in one team. So we have to adapt with that condition. And many times the doctors can be as a logistic person also. And yeah, in rare condition, we have to do this also as the doctors. So I think that's conclude our presentation. Is my presentation is not long, but I hope it can raise awareness for the doctors that they can prepare what can be happen in the disasters situation. And also, yeah, we have to practice more and more, not only in the medical skills, but also in other skills required in the disaster site. Thank you. From me, back to you, Dr. Fahad.
Thank you, Dr. Corona. Thank you for your presentation. So the role of medical doctor at disaster, not only just a be doctor, not only to assess and to treat, but it will be great. You should become a leader and also medical coordinator in disaster management. And it is another field of medical community practice. We should learn a lot about disaster management because the field is a little bit different from medical practice. Thank you, Dr. Corona. So we continue to next presentation. To the next topic, we have Dr. Kentaro Watanabe as a speaker.
Okay.
The topic is about head trauma management update. So the Dr. Watanabe graduate as medical doctor in 2004 from Tokyo GK University School of Medicine, and he started neurosurgery residencies in 2006 and become chief of neurosurgery in 2010. And nowadays, since 2017, he became professor of Tokyo GK University Hospital. He also a member of Japan Skull-Based Society and European Skull-Based Society. So I invite you, Dr. Watanabe, please.
Thank you for inviting me, and it's a great honor to be here. And today's my topic is head trauma. I'm a neurosurgeon in GK University, and then I will talk about the management of head injury and update. So first of all, thank you for inviting me in this good webinar. Last year, so I went Jakarta, and then I was invited to the dissection course in Indonesia, and it was good experience for me, and so it was very good atmosphere, and thank you for the great friendship in Indonesia and Japan. So today's topics and history of head trauma and what is a head trauma, and a secondary injury and concussion in sport. So here, this is a graph. So you can see that in 1970s, there's a lot of the head trauma and accident. And then after that, the will go down. And then after 1980s, there's a number of the injury and accident that increase and it go down now. So, you know, there's a traffic accident is a very severe cause of the head trauma. So you see, maybe Indonesia is it's a very famous. Badminton is very famous sport in Indonesia. And then here Momota is very famous in Indonesia also, I think. And you know that the bike accident is very severe. It's the worst cause of the head trauma. So when I visited Jakarta, there's a lot of the bikes like this. I saw that it's a little bit dangerous. I felt. So it's, you know, that the brain injury is going to be the critical. So that's why we need to the control. So in GK University, so we have the project in Japan Neuro Trauma Data Bank from 1998 to 2015. So when you see this graph, so in 1998, the severe severe patient is 800, and after that, after project, that's going to be decreased. And but there's not severe patient, it will increase like this. So because of that here, this when you see that here, this graph, as a transportation and infrastructures developed, and then the car accident and injury is going down. But after that, the increasing car number is increasing. Then the injury and the accident is increased again. And then, but after the government is a seatbelt promotion and alcohol check, and then after this working project, the injury and accident number is decreased. And then in nowadays, the development of the machines, you know, the camera or some a lot of monitoring. So the patient, death patient is decreased now. So promotion is very important. So, you know, the bike traffic. So in the helmet is very useful instrument for the bike to prevent the severe trauma. And also the seat belt and airbag, and also the alcohol check is very important to protect the to the people from the car traffic accident. But in Japan now, the alcohol check is very severe. If somebody has a traffic accident with alcohol, he loses his social status. Even the medical doctors, if you drink and then you drive and then something happen, you lose the medical doctors. So it's very severe. So, but this promotion, after this promotion, here this is the number of the patient of each ages. So in 1980s, 1990s, 1998, the young patient, there's a two peak. There's the gray bar, this one, and there's a two peaks, young age and older age. But after the project, young patient, the trauma number is decrease, but now is a aged patient and the trauma number is a little bit increased. That's a little bit changing now. So 1998, the young patient, was a traumatic head injury causing by the car accident. But now it's the population is a little bit changing. So now it's the aged patient, but not severe traumatic head injury, and because of the fall down. So a little bit changing now. So what is a head trauma? So we need to know that this head trauma. So head trauma is a damage caused by the direct external impact. So when you see that the anatomical structure with the head skin from skin to brain, there's a skin and garria and bone and dura and arachnoid and brain. That is very important structures. When the patient has a trauma like this, so we have to know that these layers. So at first, in the skin and the garria and periosteum and the bone and dura and arachnoid and the brain. And then we call that below the skin, there's a subcutaneous layer, and then below the garria, the subgarrial layer, and then below the bone, there's an epidural layer, and then below the dura, there's a subdural area, and then below the arachnoid, subarachnoid layers. That depends on the depth. This layer is very important to manage of the head trauma. So each layers have some. If there's something happening in each layer, we have to treat it over each for each layers. So first, in the skin wound, it's a subcutaneous hematoma, subgarrial hematoma. It's very common. It's very easy to treat it. So subcutaneous hematoma, subgarrial hematoma. Even this, so we can just treat it. And the next layer is the fractures, the bone skull fractures. The trauma is very severe, and then the bone is fractured. And next in the epidural hematoma, below the bone and between the bone and dura, there's a very strong connection. So, but there's arteries. So if the bone fracture, and with the artery damage, the hematoma is separate the dura from the bone. And then when you see the CT scan, here, this is the epidural hematoma. The artery, the hematoma separate the dura from the bone. That's why this shape of the hematoma is like this. But because of the arterial bleeding, when you see the dura, surface of the dura, there's a very big artery. We call that the middle meningeal artery. If the artery is a tear, the bleeding and separate the dura from the bone. That's the epidural hematoma. And next is the subdural hematoma. When you see the here, this is a dura and brain. Between the dura and the brain, there's a arachnoid on the surface of the brain. And also between two, there is a bridging vein here. But between the dura and the arachnoid, there is a very loose space. So if the artery, the vein, the tear or bleeding from the vein, the blood is spread very easy to this subdural space. So that's why this CT scan, we can see that the hematoma is following the surface of the brain. It means that the arachnoid, covered arachnoid protect the brain, but the hematoma is very spreaded very easy. So next is a subarachnoid hemorrhage and or brain contusion, contusional hematoma. If you see that the CT scan like this, the hemorrhage is going to the sulcus of the brain. That is the subarachnoid hemorrhage. Goes to on the brain, there's some very thin, but it's a little bit strong layers, which called the subarachnoid. So arachnoid protect the brain, but if below of the arachnoid, there is an artery on the brain. So if the brain is damaged or if the artery damaged around here, so the bleeding is going to the subarachnoid hemorrhage. So that's a little bit different. Is the famous subarachnoid hemorrhage? It's caused the aneurysmal bleeding, but this is caused by trauma. So if the name of the subarachnoid hemorrhage is the same, but it's the cause is a little different. So and here, this is a contusional hematoma. So because of the brain damage, if the brain is damaged and then the bleeding from the brain, so there's also this the hematoma. The bleeding is going to the subarachnoid space. And also that we need to know that the brain concussion, even though that the CT scan and MRI doesn't show that any damage of the brain, but inside of the brain, there's something happen because the brain is very soft tissue, and then so it's very easy to damage. And also the diffuse axonal injury, it's very severe damage in the brain. When you see that the T2 star or diffusion or SWI image, they show that a very small small hemorrhage in the brain. But it's even the small bleeding like this. It means that it shows that the brain has a lot of damage. We cannot see it, but it's happened. Because of the brain has a lot of the fibers like this, and so if the damage of the if the brain damaged all the brain, so the fibers may damage very severely. So as a treatment, skin wound, subcutaneous hematoma, subgallagher hematoma. So it's very easy. So so the anesthesia and wash and remove the contamination and sterilize and wash, and then sutures. That's very easy. And then the next, the skull fractures. There's two types of skull fractures: decompression fracture or linear fractures. It depends on the. It's a little bit different treatment. If the linear fracture like this, we can see it, just look and see it, and then wait. But decompressed fracture like this, we need to repair. We need in the treatment. So for the cosmetic. So we need to open the skin and then exposing the fracture segment and repair like this. It's not complicated. But if you see that there's one fracture on the temporal bone or frontal sinus or middle fossa, we have to be careful because of the in temporal bone. There's a lot of important structures inside of the temporal bone. There's a facial nerve or cochlea, semicircular canal, and also it's a very here. This is a little bit complicated place. So if it's the fracture in the temporal bone, it's maybe there's a CSF leak because of the dura is a tears because of the bone fractures. And and also the frontal sinus fracture is very important. We have to be careful because of the frontal sinus. The sinus is outside of the body. So if the fracture on the in the frontal sinus, there's a risk of the infection. So if you see that the neurocephalus like this, so you have to be careful and control the infection, or sometimes we have to open and repair this. So next is epidural hematoma. So here, this is the emergency case. If you see that the bone fracture, and if you see the bone fracture like this, it means it's a bone fracture on the artery. So if you see the fracture, and it should be the artery located on the fractures, the fracture lines, it's going to be a increased hematoma. So for example, this case, if you see that the epidural hematoma like this, if the patient is a stable, we can see, but we need the CT scan image. 1 hour later, the hematoma is increasing, and then the hematoma starting to compress the brain. So we need the emergency surgery. So this is a very, we have to be very quickly to go to the emergency room and call the anesthesia and call to the operation room and then run to the operation room. So operation is we need the craniotomy, open the bone and remove the hematoma and finding the bleeding artery and hemostasis. It's not complicated, but it's a very emergency, and it depends on the timing. You can save the patient or not. It's very it's controversial. But so we have to know that this artery, medial meningeal artery, and also the other cause of the supersagittal sinus, not artery, but it's a very big vein is located in the center of the head. So the vein is already fragile. So if see that the patient like this type of hematoma, it's the sagittal sinus is located the midline of the or center of the brain. So if the bone fracture is on the supersagittal sinus, it should be open, and we should operate. We have to be careful of this. This is a case of the subdural epidural hematoma causing the sagittal sinus, supersagittal sinus trauma. And then here, so we have we put bar holes around the fractures, and then open the bone, and then evacuate the hematoma, and then finding the bleeding point, and then compressed, and then hemostasis very carefully, and then complete hemostasis. We need the tuck-in sutures. So to hemostasis of these areas, we need that sutured the dura to the bone. That is a very important technique. And also after that, we need to identify the inside of the dura. Then hemostasis. Then tenting. Then repair. That's it. So this type of the fracture also is very important. So we have to be careful like this. If the fracture on the located the medial meningeal artery or sinus, we should be careful. During surgery, compression and hemostasis and the trenching suture, the technique is the most important. And next is the subdural hematoma. See, there's a two types of the subdural hematoma. It is acute or chronic. So the chronic subdural hematoma is the most common disease in the neurosurgeon. And acute subdural hematoma, it's the same subdural hematoma, but is totally different. Treatment is totally different. So chronic subdural hematoma is the most easiest treatment for the neurosurgeon. So it's very simple surgery, one bore hole and irrigation surgery. When you see here, there's like a moon or like a shape like this, boomerangs like this. But inside of the hematoma is a liquid. So the typical history of the subdural hematoma, a patient fall down and his hit his head on the street 1 month ago. And one day the patient felt his arm and foot weakness on the right side, and the CT scan showed the subdural hematoma in his left side like this. But as a hematoma is a liquid hematoma. So, and also there's a small capsule. So I call the liquid hematoma in sac. So when you open the sac and then evacuate the hematoma, and then the brain push the hematoma by itself, and then treat it. It's very simple. One bore hole, 3 centimeter incision, and make exploding the bone, and then one bore hole and irrigation. That's it. So, but sometimes patient has a very severe hemiparesis or conscious disturbance. But after surgery, you know, the local anesthesia, 30 minutes operation, recover, and a few days of hospitalization, and then go back to home. It's like a magic surgery, but it's the most common common disease in neurosurgery. But when you see that, talking the acute subdural hematoma like this, it's the same subdural hematoma, but it's totally different. The subacute, the acute subdural hematoma causing the bridging vein the bleeding. So when this CT scan see that the small hematoma like this, and because of the bridging vein bleeding, it's not arterial bleeding. Sometimes it's happened arterial bleeding, but it's most of the cases the bridging vein bleeding. This is a case of the subdural hematoma and the operation. But it's not we cannot treat the one by one bore hole, so because of the hematoma is very hard. So we need to open the very large craniotomy, and then open the dura, and then see that the hematoma, then evacuate the hematoma, and then repaired. Then it's treated. But they need the large opening. It's totally different compared with chronic subdural hematoma. But and also that the acute subdural hematoma is a very different, and on the postoperative cause depend on the time on the brain damage. If you see that in this case, the brain is more relaxed. That's just, but the bleeding is increasing, so need to operate. And but the after operation, the patient is recovered very well. But if you see that the subdural hematoma like this, it's the brain's already tight, so there's no recovery from this. But it's depend on the time and also the initial damage. So this case is it's not so severe, but it's already brain is damaged. Even then after surgery, there's opening the dura and the external decompression after surgery. But even though like this, the brain's already dead. So these patients were dead after the surgery. Because of the second injury, we need to know that the second injury, that's very important. So second injury is the brain damage due to the indirect effect. So if the hematoma is increasing, and then if take a long time to treat, to evacuate a hematoma, so it's going to be brain swelling, brain herniation, and compression of the brain arteries. So if we lost the timing, the brain, this damage is happen. So very important. We need to, the decision is very important. So this is a danger sign. So anisocoria, the conscious disturbance and respiratory disorders, it's very, we have to be careful to see the patient and see that if this danger sign that we have to decide to operate. So, but initial damage cannot be controlled, you know, the brain is a very soft tissue, and it's a very control the very, it's a very sensitive organs. So if the see that these CT scan like this and subdural hematoma, but with the brain contusion, the frontal base or temporal tip or temporal base, these areas we have to be careful to see that, because of the they're very easy to damage around here. So you see that the round shape brain. So if the damage from the posterior head, the brain is going to the frontal damage, or sometimes the brain is a slide on the frontal base or slide in the temporal base. It may be damaged. So if you see that this contusion, we have maybe the patient already had a lot of damage on the brain. Subarachnoid hemorrhage also, if you see that subarachnoid hemorrhage, the brain may be damaged, and also the brain contusion is very severe. The patient will have the severe complications after trauma. So the SWI image, it shows that the very, so be careful precisely the damage of the brain. If you see that SWI image, here you can see the small spot on the brain, all the brain. You see, this is it shows the axonal diffuse axonal image injury. So here there's when you open the skull and open the dura, it's already swelling the brain like this, and also the subarachnoid hemorrhage. It means that you see that very swelling like this. It's a little bit it's a really miserable outcome after the surgery. So it's depend on the initial damage. If you see the patient has the Glasgow scale is good, we can wait and see. But the patient going down, the conscious is good, the decrease. We need the blood pressure control, the anti-epilepsy therapy, and also that we need the surgical treatment, and then evacuation, hematoma, extended decompression, and it's going to rehabilitation. It's very good. It's maybe this way is good, but in initial damage, it's very critical. So we cannot go to the rehabilitation. We have to see that we have to decide the patient will operate or not, or the hypothermia therapy is it's not so effective. So the decision making is very important for the neurosurgeon. So you see that here there's a fibers, and the brain is a lot of fibers. When you see that if the damage on the brain is these fibers should be damaged. So we have to think about this, and also that the brain, the brainstem, all the fibers concentrated in the brainstem, and the brainstem is very easy to damage also. So brain. So we need to control of the we need to treat of the, and also the decision making is very important. So emergency system management is most important, and timing and initial brain damage, we have to predict the brain damage. So when you get, if I do the emergency surgery, so we have to, my decision is to save the patient or life or not, it's very important. So, but to prevent the initial damage, there's the doctors, we cannot prevent the initial damage. The head protection promotion is very important, you know, make so like a project is a good outcome like this. So next is head trauma due to sports. It's nowadays in the head trauma is also very important. The head trauma and the concussion is very important. This is an important topic. In United States, also concussion is one of the social problem of that here. Because in the FIFA or also rugby, or you see that a lot of concussion. We saw that a lot of the case of the concussion in FIFA. There's a concussion 5 cases in rugby and 24 cases in this World Cup. So we have to control. We have to know how to control the concussion. But in United States, American football, after promotion, the concussion rate is going to decrease, and then death people also the decrease. That's very important to save the players. So you see that here there's a simulation of the brain concussion, brain trauma. In sport, it's this occasion is it's very happen. It's like this. So here is the inside of the brain. There's a very, you see here, the red part is damaged here, brainstem and temporal lobe, or you know that there is the falcus or tentrium. There's a strong structure around here. There's the brain damage around here. So if you see that the acute symptom after the trauma in sport, constant disturbance, headache, nausea, dizziness, unbalance, or loss of the concentration, memory loss, irritation, like this. So we have to be careful. So if you see the players, they have the patient, they have the symptom like this, they never to go back to the play. Same day return is never. We should stop. And step by step return following the guideline is very important. And also the chronic syndrome, you know, so after if the patient has a head trauma and then the second impact in the same game, the patient will have the very severe complication after the second impact. And also that if the players have the multiple head trauma, they will have the chronic traumatic encephalopathy or punch drunk syndromes. It should be happen. We have to know that about. We have to know that for the neurosurgeons. There's a SCAT5, the protocol to recovery program. So it's a little bit complicated, but we need to follow this protocol. So, but if you see that the patient, the players have this symptom, we have to stop. We have to say to the player to stop the game. So recovery program. So we have to we have the patient to take a rest and then start the walking after SCAT5, after checking that the symptom, and they start to run. And then after that, they have to check again and then go back to sport again. we should educate the coach and the players and the societies. It's very important to save the players and the player's life. So brain concussion management is also very important for the neurosurgeon. This is our works also. So this is a take home message. Head trauma, so you can save the patient. Don't miss a timing to decide the surgery. Timing is very important. And the concussion, we should be careful to give brain damage, even if the CT scan doesn't show that any sign, indication to the players, coaches, and the sports societies. It's very important. So I'm skull-based neurosurgeon. So I'm not so traumatic surgeon, but so I have a lot of the complicated surgery. So I have the Instagram for the brain surgery. So if you're interested in the skull-based neurosurgery, so you can see that it is Instagram. Thank you.
Thank you, Dr. Watanabe. What a very good presentation. Let the picture tell the story. Your picture is very nice. Okay, so we move to third speaker. We move to third speaker. Next topics, our speaker is Professor Takeshi Miyawaki, with the lecture title, Management of Soft Tissue Wound and Facial Bone Fracture. Professor Miyawaki graduated from GK University School of Medicine in 1989 and then became a chief professor in Department of Plastic and Reconstructive Surgery at the GK University School of Medicine in 2015. He is a member of Japan Society of Plastic and Reconstructive Surgery and also Japan Surgery and American Society of Plastic Surgeons. I invite you, Professor Miyawaki, to speak your presentation, please.
Can you hear me?
Yes, Professor.
Thank you very much for nice introducing me. I'm Dr. Miyawaki from GK University School of Medicine, and I'm a plastic surgeon. And my main specialty is craniofacial surgery, the facial surgery with the bone work. So I'd like to share with you today with my experience with the wound care and also facial trauma. Do you see my slide? Can you see my slide?
Yeah.
Yes?
Yes.
This is the first slide, the title slide.
Yes.
Okay, I'll start my presentation. So the contents of this lecture contains background of wound healing, primary and secondary wound healing, and also wound closure. And I also like to share my case presentation with all of you. So first of all, I'd like to ask all the participants with this question. So when should the fresh wound be sutured? We always see those simple wound at the emergency or daily clinics. So when you see the wound at the face and head and neck area, you should close the wound within 24 hours because there are so many blood supply to the area. And when you treat the wound around the trunk and also extremities, you should close them within 6 to 12 hours. But the sooner the better when you treat the wound. So does tap water cleansing of contaminated wound help reduce infection? Yes. Whenever you see a wound, you should remove all the foreign bodies or the debris and also clean with the tap water, as long as the tap water is hygiene enough. So the next question is, does debridement of the contaminated wound help reduce infection? Of course, yes. The removal of necrosed tissue is effective. And but please preserve as much tissue as possible to avoid potential deformity. So if you excise more, then you leave deformity. So please be careful. So now let's talk about wound healing itself. The wound is divided into or defined as two different names, acute wound and chronic wound. The acute wound is a fresh wound, which is a result of surgical incision or trauma. And it is supposed to be healed in a timely or orderly manner. Whereas a chronic wound doesn't heal it takes more than 4 weeks, and there is no sign of improvement for 2 weeks. And there's a sign of inflammation and which is resistant to antibiotic treatment. This is a skin anatomy schema, and you know all of these structures. And as long as the scar wound does go superficially to the half of the skin, it usually doesn't leave any scar, but it goes deep down to the basal cells or dermis layer, it may leave scar. So you have to know the depths of the scar, the wound. And the wound healing is divided into 4 stages. From the onset to the 6 hours, which is called coagulation stage. After 6 hours to 3 days, which is called inflammation stage. And after that to up to 7 days, which is proliferation stage. And finally, the wound will, goes into the maturation stage. The first step, the coagulation phase, the wound cut edge has bleeding and it makes a blood clots. And then inflammatory phase, there are so many cells, inflammatory cells, and cytokines get into the wound edge to remodel or start healing the wound. And then the proliferation phase, fibroblast and basal cells, new vessels, macrophages, all gathered together into the wound. And then finally, it goes into the maturation stage. During the maturation or wound healing stage, there are so many chemical mediators well known as TGF, alpha, beta, and VEGF, fibroblast growth factors. Those are intact with the fibroblasts to heal the wound. So during those stages, what are the most adequate treatment? In between the inflammation and proliferation stage, the adequate debridement of the wound and also moisturization is essential. This is a case example of superficial wound. You debride the wound and apply a fresh sponge and film dressing to moisturize the wound. Then it heals very nicely within 4 days. If this healing stage goes by The frequent dressing change should be avoided as to allow proliferation of fibroblast and epidermal cells into the defect. I'm really sorry to show this written in Japanese, but there are so many dressing items available in the market. So we have to choose whatever needed for best to treat the wound. This is a schematic flow of choosing which kind of dressing to cover the wound. If the wound is shallow and simple, then hydrocolloid or film dressing comes for the first thing to use. And if the volume of exudate becomes large, then negative pressure wound treatment works well. In between those two, you can choose foams or alginate hydrofibers. This is a case example of a surgical wound with film dressing. It can be left for 7 days until the stitches will be removed. This is another dressing made of hydrocolloid, which is available in the pharmacy over the counter. And it stays very nicely for a couple of days. And it gives also a moisturization to the scar. If the exudate of the wound becomes larger, then you can use hydrocyte kind of forms that accumulates the fluid. In such cases, exudate from the wound is more than the simple scar, so you can apply alginate to accumulate the wound fluid. If you see this kind of deep and wide scar, this is cardiovascular surgery scars, and it is now osteomyelitis of the is there. So we have to divide the bone and muscles. In this situation, negative pressure wound treatment works well. Negative pressure wound therapy looks like this. You apply a sponge, non-adhesive sponge into the defect, and apply a negative pressure to vacuum the exudate. These are the commercial-based devices available in the market, and the back system is the most popular one. The theory of the negative pressure wound treatment is as follows. The first, neovascularization. When you apply negative pressure to the wound, the neovascularization happens, and also edema will be reduced. And also you can vacuum the exudate through the vacuum duct. And the macro deformation, which shrinks and contracts the wound. And also it promotes growth factors, cytokines, and granulations. And it also has effect of wound control, which can protect cells from drying and controls body temperature, as well as controls contaminations. So this is the final device that you can use to treat the deep, wide, or contaminated wound. So there's another way to describe wound healing, which is primary wound healing or secondary wound healing. The primary wound healing gives a better scar or no or visible scars, whereas secondary wound healing leaves a scarring. So primary wound healing is the most ideal way to treat the wound. This is very typical, typical primary wound healing. This is a case of a cleft lip and palate. And this is just after surgery and 3 years after surgery. So when you cut the skin with a sharp knife, making a sharp edge of the wound, then you can create a very nice scar, which is called primary wound healing. This is another case example of secondary wound healing. This girl was playing with the bamboo stick, putting in her mouth, and unfortunately she fell off and the bamboo stick stuck into her mouth. So she had her palatal mucosa compressed, and which lost the circulation, ended up with necrosis. So I just wait and see for just rinsing, by rinsing, and it healed very nicely within 7 days. This is another case example of secondary wound healing, which is a defective wound after dog bite. The dog bite treatment is kind of controversy. The contaminated wound can be closed after complete debridement, or you can leave it alone to heal it by itself. So I just leave the scar wound as its own and keep applying the ointment and get a result like this on your right side. It took us 2 months to heal the wound up. It looks almost nice, but when you look at closely to the lip, the red lip is composed of dry part and wet part. So the wet part was brought upward, which is unusual, unnatural. So I put him down to the OR and excised the scar. And also I placed several Z-plasties. And this is a final result. So when you cut the skin with a knife to create the sharp edge of the wound, you can make a very nice scar. So now you understand that if you treat the wound long, then you see a delayed healing, marked scarring, and contracture. If you treat the wound adequately, then the scar will be invisible, acceptable, and scar without contracture. So this is some points that you can understand what suppresses the wound healing and what promotes the wound healing. What suppresses the wound healing? Infection, mechanical stress, instability and dermatitis, dryness, poor circulation, ischemia, paralysis, and medication such as steroid, and the background of diabetes, immune deficit, or poor nutrition. And sometimes aging suppresses the wound healing. So the wound treatment in the past, disinfection with sponge coverage and keep it dry. Those are 3 items that we always propose to the patient. But now, saline irrigation, wound dressing, and specific ointment spray. Spray means we have very nice medicine, beta FGF spray, which works very well. So we have so many different items that can help improve the wound's healing. So this is the current way of thinking to treat the wound. So this is a situation we treated with the facial bone fractures. Whenever we close the wound, we always wash the hair. The blood on the hair will be bad for the infection. So we always wash the hair after surgery. This is the situation we wash the hair just after surgery. The suture technique also important. Those are always described in the textbook of surgery. And all these schema is showing eversion of the edge of the wound. Eversion means elevation of the edge of the scar, the wound. The top one is simple interrupted suture, which is well known. And also the second row is interrupted dermal suture, which reduces the tension at the wound. So reducing the tension at the wound is the key to get the better scar. And the bottom one is horizontal matrix sutures. This is also nice to reduce the tension, but you may leave the suture mark. So what is suture mark? Suture mark is kind of iatrogenic marks. So when you look at the first situation, you don't see any suture marks. The suture marks is the too much pressure to the wound created by the suture. So please do not make these suture marks. This is a case of Caucasian, so you don't see any visible scar, but Asian skin doesn't heal like Caucasian. And once you make the suture mark, it will not fade by time. So please try not to leave the suture mark. So how to prevent a stitch mark, suture marks? Usually we take the stitches off at around 5 to 7 days after the treatment. But at the time, the wound strength is just about 10% compared to the matured scar. So we have to have a certain type of technique to reduce the tension at the wound, which is dermal suture. So you have to use the dermal suture technique. And when do you know when the wound gets strong enough? By looking at this schema, 12 months to 14 months, the wound becomes strong enough. The wound breaking strength is almost maximized at 3 to 4 months after the treatment. So please remember this timing. So when you remove the stitch, the wound is not strong enough. When thinking about creating a better scar, you have to know the anatomy of the structures. This was sutured by someone else, and you can see the gap between the here. The round mark of the lip has a gap like this. So you have to be very careful when suturing those structures. And also you have to be very careful about removing the foreign or foreign body. This is a teeth, so you have to remove this before suturing, of course. And sometimes you don't see it through the wound. This is a lady, she fell off on the wine glass. So we took a CT scan, and CT scan is showing foreign body around the mandible. So when you look back into the wound, this is a glass, the debris of glass. So we have to take it out before closing the wound. And also the hematoma is the enemy of wound healing. So whenever you see swelling, then just remove the blood out from the area. This is a bad end of the hematoma. Hematoma may cause skin necrosis like this. So we have to divide the skin as well as the hematoma below the skin, enclosed skin. In this situation, we have to have skin graft over it. And it took her about 6 months to heal this wound up. When treating these complicated situation, we have to be very knowledgeable about the structural anatomical structures. So we, in the left below slide is showing cannulating the lacrimal system. We have to reconstruct all these structures. This is a lacrimal system. So the previous slide is showing the canalicus cannulation. Okay. This is another case example of scar, the wound. He was a repairman of a hand dryer. Hand dryer is always used in the toilet, and dryer has a turbine which is very hot. Unfortunately, during the repairing, the blade was broken and stuck into his face in a very high temperature. So he had a laceration as well as burn on his cheek. And when you see a scar, the wound around the face, you have to be very, very careful about checking the facial nerve. The below is showing the facial nerve, which is a marginalis branch of the facial nerve. Fortunately, it was intact, so we closed the wound. But still, he has a burn around the wound, so it heals like this. So it left a hypertrophic scar. It's not a good scar. This is another case example of tongue laceration. He was playing with his younger brother and jumped off from high place and cut his tongue with his teeth. So we just debride the edge of the wound and suture it back into place, and it heals very nicely. So treat the wound nicely to create a better wound. You sometimes see this kind of trapdoor injuries in elderly patient. This is like a skin graft. So put it back, all the structures into place and suture with a very small sutures. In this situation, I used 6-0 nylon. But the skin is very, fragile. So you should apply tape to prevent tearing of the skin. And also, as I mentioned before, that the hematoma is an enemy of the wound healing. So I applied a small drain into the scar, into the wound. This is the result of this patient. This is another case example of severe open comminuted fracture of the nose. And the bilateral frontal process of the maxilla was broken. So layer to layer fashion closure of the wound is necessary. And this is a final result of the patient. This is a very recent case we had last week. We usually treat facial bone fracture about 180 cases per year. But after the pandemic, that means after last year, last February, last year, we only had 5 cases of facial fractures. Only 5, but those are very severe. This lady has also a very severe fracture on her face. But you can't tell how much, how complex this fracture is from outside. She had her right face severely hit by the other players when she was playing soccer. The eyeball movement was not impaired, but when you look at the CT scan, she has a comminuted midface fracture which is right zygomatic fracture, the right temporal bone fracture, and right naso-orbital ethmoidal fracture, and LUFO1 sagittal fracture, as well as right orbital wall fractures, which extends into the three-quarter of the orbital walls. This is very severe fractures, which is always said to be like high energy trauma. So she was put on the bed, and when you treat the maxillary occlusion, we have to intubate from the nose or tracheostomy or submental intubation. But in this situation, she has to go through the bicolonal incision. So we decided to choose submental intubation to avoid tracheostomy. So opening up the wound through the oral approach, we first divided the incomplete fracture by using an osteotome to mobilize the fragment. Then apply the palatal plate, which was prefabricated beforehand. And then reduce all these bones back into place and plated. From above, we access to the nasal root to fix the maxillary frontal process of the maxilla, and also frontal zygomatic suture and arch, and zygomatic arch. And this one, the most behind screw, is fixating the zygomatic process of the temporal bone. And finally, we fix the orbital walls. She has 3 wall fracture of the orbit: the lateral wall, lower floor of the orbit, and also medial wall of the orbit. So this is the result of the patient. Those right blue ones are the plates. And this is the plates used in the orbital reconstruction. This is the pre-op CT, and this is post-op. So the malar eminence is reduced back into place. So the symmetry was obtained. And this is the 7 days after surgery. The ocular movement is a little bit impaired on the right side. The lower vision, lower movement of the eyeball is still impaired, but it takes time to heal up. Usually it takes about 2 to 3 weeks. This is a final result, and the scarring and occlusion at the time, 7 days after surgery. So I'd like to summarize my presentation. Please wash and clean the wound first, and remove all the foreign bodies, debride as needed. Please debride less in face, as it heals better with leech circulation. Hand wound also follows the principles of facial wound, and avoid hematoma formation. Thank you very much.
Thank you, Professor. Thank you for the presentation.
What
advanced cases you take? So this is the last topic and of the second session. Next, we move to Q&A session. I see there are already quite many questions. Please, committee, to share the question. Okay. First question from Dr. Irena. Dr. Irena has a question to Dr. Corona. How to apply current pandemic-related health practices in disaster area?
Okay, thank you for the nice questions. Yeah, actually, it's kind of hard challenges for any disaster team during this pandemic situation. So in MDMC, we already established specific procedures, which is conducted mandatory by all the medical team in the disaster area. We adding some specific logistic requirements such as PPE and hand sanitizer for all medical teams. And we also obligate them to, like implement the swab test before they are assigned to the disaster area. So also we made a specific procedure for any medical posts, such as maintain the distance when they are eating together, and also make sure that all the medical posts have a good ventilation, such kind of that. So yeah, thank God until now we don't have like any big issue about the medical team related to the coronavirus infections.
Okay, Dr. Corona, I also have a question. Since the vaccination of COVID has begun in our country, it is mandatory to all medical team before go to disaster area.
We still advocate the government for that, because in the strategy, a big strategy of the government, the disaster volunteers doesn't involve yet, and now they are having discussion about getting the volunteers into the main priority for the vaccination programs. So it's still going on the advocacy process for that specific issue.
Yeah, I think it should be. It is must, I think.
Yeah, but because the availability of the vaccine is not widely available, so it's kind of like.
Okay, Dr. Kurana, I also curious because this disaster is different area from medical science. I also curious, what is the main emergency building should be stand to provide the needs of survivor, either medical needs or other needs? What is the main emergency building should be stand?
I beg your pardon. The facility. I mean.
Yeah. I mean the facility should be stand to provide the needs of survivor.
Yes, I think depends on the what kind of the hazard in that area, disaster area. So any kind of the medical facility must cope with that hazard, specific hazard. For example, when we're dealing with earthquakes prone area, so all the building should should be built according to that. But unfortunately, we are aware that in Indonesia, not all hospital or medical facility fulfill that criteria of the disaster, like disaster related.
So you get used to build like hospital, emergency hospital or emergency clinic at there, right?
Yeah. Depends on the, if for example, if we are going to the cyclone or the heavy rain, so we have to prioritize that permanent building will be used. But when we are deployed to the earthquake, so yeah, we bring the tent, for example. It's easier and safer for us in the earthquake disasters, some kind of that.
Okay, thank you, Dr. Corona. Maybe there is another question. To Dr. Kentaro Watanabe from Berry, he is a general surgery resident. How to manage mild head injury with epidural hematoma on posterior fossa with linear fracture? When do we consider to operate? And the second question, and for a pneumocephal with fracture of posterior table of frontal sinus, when do you consider to operate?
Oh, thank you for the questions. Oh, first question of the head injury within the epidural hematoma on the posterior fossa with a linear fracture. So if the patient has no symptom of the from the hematoma, so we don't need to operate. But we have to be careful of the linear fracture on the sinus, like a transverse sinus or sigmoid sinus. We have to be careful. We have to check the sinus, or sometimes the sinus is going to be occlude and sinus thrombosis should be happen. So we have to be careful. And next question is that pneumocephalus with the fracture of the posterior table of the frontal sinus. What do you consider to operate? Only posterior posterior table.
Yes.
Pneumocephalus with the posterior table is the front of the frontal sinus. It's mean what? The posterior table of frontal sinus. If the we can wait and see that if the large pneumocephalus and CSF leak, we should repair. But if the patient has only the pneumocephalus and the posterior fracture on the frontal sinus, we can wait. And we have to check and again the CT scan again and again. And if the patient has the CSF leak, only CSF leak, we can put the spinal drain and then wait. But if the patient has the pneumocephalus and the CSF leak, it's a little bit complicated. We have to see, and then we have to repair or something like that.
Okay, thank you, Dr. Watanabe. Actually, I'm kind of forgot. What is there any dangerous structure in posterior fossa, doctor?
What?
It is a dangerous structure on the posterior fossa.
If the fracture on the sinus, like the transverse sinus or sigmoid sinus, we have to be careful because of the sinus bleeding. It should be going to the epidural hematoma or subdural hematoma.
Okay, thank you, Dr. Watanabe.
You're welcome.
So the sinus. Okay, the next question to Prof. Miyawaki from Professor Taka Fujimaki from Saitama University. Professor Miyawaki, you mentioned that if the wound is deep, we feel face scar formation. Can we do anything to reduce or to avoid the scar formation?
Thank you very much for asking. When you close the wound, deep wound, then apply a suture in layer and layer to layer fashion. So you close the deep fascia, fat, and also dermis to reduce the tension at epidermis, which is the key to reduce the scarring.
Okay, so the key is no tension, yeah?
notation on the superficial part of the skin.
Technically, we can do like undermining technique, right?
Well, undermining is sometimes works, but reducing simple wound suture, closing simple wound closure means there's no defect. If there's a defect, then you have to undermine. But also during the undermining process, you are creating a scar. You'll be creating scar. Undermined area also heals by scarring.
Okay.
Okay.
Thank you. So, Professor Miyawaki, I want to know what is your consideration to determine whether the scar you will do primary suture or secondary healing. What is your consideration?
Well, as I mentioned in the very first slides, if you see the patient before 12 hours, then you can suture the wound in extremities of the trunk. If you see the patient after that area at the time, after 12 hours, then if you suture or leave it, let it heal as a secondary, it doesn't make any difference.
Okay, I see.
So the timing when you see the patient is the key, which way to go. And also the contamination is another thing to consider.
I see.
Like I mentioned, that dog bite is one of the controversy we're always discussing.
And also in chronic wound, usually heal by secondary healing or?
Yes, secondary healing.
In chronic wound. But the important still, we should do the debridement first, right?
Yes.
Okay, there is any question? Again for Dr. Corona, from Dr. Putri. Dr. Putri, she is a specialist in forensic medicine. The question is, how do you handle ethical issues in disaster management? Like ethical aspect of triage, resource management, physician burnout, and etc.
For the ethical issue, we have also specific procedures. And of course, we maintain education and for the patient and also the patient relative. And for the physician burnout, it is a job of the team leader to look out for all the team members, whether it's related with the physical burnout or the psychological burnouts. So in the standard of the EMT, we have also a psychologist in our EMT members. So that psychologist is have the specific function to deal with such matters.
Okay. Dr. Corona, ideally you make a shift to the medical team for every hour, for maybe for 6 hour, 8 hour, or what? Or
Yeah, depend on the type of the EMT. In EMT type 1, usually it's only a day work hours. So we usually open from 8 to 4 or 5 p.m. But it, of course, depends on the situation. For example, when last week we deploy our team to the East Flores, the site of the refugee is far away from our camp, so we have to dispatch a mobile team to that site because the trip is quite long. So we are trying to manage and shorten the services for the refugee. For example, is we leave at 8 and at 3 p.m. we must come back from the site. But yeah, that's one of the example that we have to adapt in each different situation in disaster sites. But yeah, team leader must aware of that kind of situation and make the best treatment or the best alternative way to deal that kind of matters.
Thank you, Dr. Corona. The next question again to Dr. Kentaro Watanabe from Professor Taka Fujimaki. As for the patient with subdural hematome, whom you did decompressive craniectomy, what was the GCG, Glasgow, at the initial presentation and on arrival to the hospital?
Thank you for the questions. Actually, this case is it's not my own cases, although I don't know the exact GCS score, but it should be the GCS is very low because of the CT scans already show that the brain damage or some ischemic area of the in initial CT scan. So it's mean that the GCS is very low, I guess.
Dr. Watanabe, I have a question, the important question. In the case of multiple trauma, let's say it involves head injury and abdominal injury, and then the patient with unconsciousness condition. So how to determine whether the unconsciousness caused by head injury or other injury?
It's depend on the situation. So if it's very difficult. So if you have the hybrid OR, so you can treat the both side, like internal embolization or a trauma operation is the same time. But it's depend on the situation. So if the epidural hematoma arterial bleeding, we cannot wait. So we can put a small hole and evacuate this hematoma as much as possible, and then move to the abdominal surgery. So like that, we have to think about the which artery or which vein or the situation of the head injury or the how severe of the bleeding level. So that's it. It depends. We have to discuss with the other services.
Okay, thank you. Thank you, Dr. Watanabe. Dr. Watanabe, is there any clinical signs to see whether, like maybe, if I remember, lateralization sign, like an isochor pupil,
or respiratory disorder or conscious disturbance. It's very important to know that this is a dangerous sign.
Yeah. Okay. Thank you, Dr. Watanabe, for the explanation.
You're welcome.
The next question from Henry from Surabaya to Professor Miyawaki. Professor, the tools or technology in Indonesia, especially in remote area, isn't as equipped as in Japan. Do you have simple suggestion about suturing wound to keep it moist so it heals at best?
Thank you, Henry, for asking. He spent almost 2 years with us as a visiting fellow at my university. He's a very nice guy. Thank you very much for asking. When you finish closing up the wound, then you can apply an ointment, such as gentamicin ointment or whatever ointment is fine. Just apply a small portion of ointment over the stitches. That can help keep the wound moist.
Yeah.
And one more alternative is to use the kitchen wrap to cover the wound. It also helps keep the wound moist as well.
Thank you. Yes. Professor Miyawaki, I have good experience in treating diabetic wound or any chronic wound with honey dressing.
Honey dressing.
Honey dressing.
Thank you for comment.
What is your opinion?
Okay. Oh, I'm not sure how hygiene it is.
Right.
Someone says that there's some microbacteria in the honey.
Fine. Okay. Thank you, Professor Miyawaki. Maybe there is participant who want to ask directly. Maybe Dr. Wawang. Okay, I read
no, thank you. No, thank you.
Please. Okay, I read the next question from Reni from Kaltim, Kalimantan Timur to Dr. Corona. When is the emergency response period considered complete at a disaster site, and who determines it?
Yeah. The disaster emergency response phase is and when the local authority said that depends on the level of the disasters. Sometimes when we talking about the provincial level of the disasters, then the governor usually release the letters state that when the emergency response phase is over, and when we deal with the district level or more below the provincial level, so the local authority usually release that kind of letters. So we follow that kind of letters, and I'm sure in parallelly we still assess whether the letter is fit with the real condition of the disasters.
Thank you, Dr. Corona. So our time is close. I think we take two more questions. Two more questions, or is there anyone to ask directly to speaker? It will be great. Okay. The second, the question to Dr. Watanabe: why acute subdural hematoma will be more severe than chronic one? Is that related to the bleeding level?
Oh, yeah, because the acute subdural hematoma has the acute bleeding. The compressing speed is very high. It's very rapid. So second injury should be occur. It's very quickly. But in chronic hematoma, it's usually the chronic hematoma patient didn't have any the hematoma in the first day, the 1 day, the after the head trauma, CT scan doesn't show any hematoma around the brain, and then but after one month ago, 1 month later, the patient has a big hematoma, but it's the increasing rate is very slow. So second injury will not happen. So just evacuation of the hematoma it's okay. But acute subdural hematoma, it's right after the head injury, the bleeding is starting, and then going to spread and then compress the brain very quickly. Then second injury should happen. So that's why the differences of the head injury, that the level of the head injury is different.
Okay. Thank you, Dr. Watanabe. What a good explanation. So the last question, it will be one closing question, maybe from Professor Yashiro.
From me?
Yes.
Okay, I do not have any questions. Thank you very much for everyone. I would like to make a short closing remark. So Dr. Fahad, thank you very much for a nice moderating for long 3 to 4 hours. Thank you very much. With your help, I think this seminar showed a great success. Thank you so much. And I would like to express my sincere gratitude to everyone participated in this seminar. And please understand, this seminar was operated by the staff of Faculty of Medicine of Hamka University. I would like to thank all the people involved there. And also, I would like to thank the 2 speakers from Indonesia, 2 speakers from Japan. And I do hope that after the COVID-19 is over, please, for Japanese speaker, you have a chance to visit Indonesia. I do hope all of you visit Indonesia and make lectures directly to the medical students and young doctors. That is my dream. Please do that. So I would be happy if I could hold another project like this one in another half year. Thank you very much for your understanding and support. Now, I should like to close this seminar. Thank you very much, everyone. Thank you, Wawan. Thank you, everyone.
Welcome.
Before we stop before we close the room, I want to ask you to open your camera, and we are going to have a short photo session, please. We have 139 participants, so I need a couple times to do the screenshot. It's already dear the participant, you can open your camera. Okay, I will take in couple times. So the first one is in 1, 2, 3. Wait a minute. 1, 2, 3. Wait. 1, 2, 3. 2 more. And the last one. Okay, that's all.
Okay. Thank you very much.
Thank you very much.
Thank you, Dr. Rizkyana.
Yeah. See you.
Thank you very much. See you.
Thank you very much, everyone.
Thank you for all the speakers.
Don't forget to fill out the questionnaire and the attendance list. The link is on the chat box. And don't forget to put your designation as you want. So you can get the certificate as your title and designation for you. And the e-certificate will be given to you by your email in several days after this session. Okay. Have a nice day, everyone. Thank you for coming to our webinar.
Thank you.
For Indonesian.
Thank you. Thank you, Professor Yashiro. Thank you.
Thank you, Professor.
Professor Mayawaki. Thank you, Pak Corona, Dr. Leli, Rizkyana.
For all.
Terima kasih, teman-teman.
For all the speakers. Enjoy your life today and tomorrow and tomorrow and tomorrow. Thank you. Oleh itu di kantor.